Without further ado, we're going to start with the first proper session on the Rose sessions, series of sessions. So we're going to start with resuscitation. Can I get the panelists up on stage here with us? And Anders and Pietro will join us online. At this time, I'm going to be joined with my friend and colleague, Jamie Strachan. Come up stage, sit down. Those of you that are sitting down there, like I've said in the first introductory sessions, we will value your interaction. We value your questions in all of this, and we're going to have discussions around the resuscitation aspects of fluid management. Okay? Jamie, if you want to take the lead, we need to introduce our panelists.
Hello. Okay, yes, my name's Jamie. Thanks, Adrian. We're stripping out the lectures from the conference, and that's a really brave thing to do, but it does require us to sort of think, we know all the knowledge, we've got it in our heads, we all do the job, and what do we want to know? So we're going to talk about the R of Rose right now, resuscitation. So I guess sometimes this is assumed to have happened and feels like something that we don't study in depth because it's always time sensitive and just happens. So perhaps gives a slight angle there. So what I propose we'll do is we'll just go along the sofa, introduce ourselves, and if you could say your name, where you work, and I guess what your favourite fluid is would be a good icebreaker for the panel, if that's okay.
Well, nice to meet everyone. I am Fleur van der Ven. I am an intensivist in Amsterdam University Medical Center in the AMC. To answer your question, what's my favorite fluid? I don't have a favorite fluid. I don't have a favorite fluid because I think fluid is one of our biggest enemies.
Good answer.
Hi everyone, I'm Fatima Parak. I'm an intensivist based in Pretoria in South Africa. Good to be here today and to see so many faces. As far as my favorite fluid is concerned, I think it still remains elusive in the era of personalized medicine. We really cannot have a one-size-fits-all, and so it's really about deliberation prior to implementation if there is a need for fluids.
Hi, and I am Niels van Regemortel from Antwerp, Belgium. I'm here for a very long time in this organization, of course. I'm an internist intensivist, so I rolled into this out of an interest in acid base. So the first thing I was doing in IFAT was the discussion between balanced solution and unbalanced solution. I kind of left that discussion now. I think it's not that important anymore, but we will discuss about it later. So my favorite fluid is gin tonic, actually, because it's hypertonic and it doesn't contain too much chloride.
Good morning. My name is Robert Hahn. I come from the southern outskirts of Stockholm in Sweden, and I've been working with fluid therapy studies for many years. Originally an anesthetist, operating room anesthetist, and now basically a researcher in this field. You want to know about my favorite fluid, right? And for the past 5 years, I've been conducting studies about hyperoncotic albumin, and I think its place in the therapy is a bit unclear still. So I favor that one, and I would like to help to place it in the correct position in the therapy.
Hello, I'm Dr. Prashant, working as an intensivist at NMC Hospital, Dubai, United Arab Emirates. I think only one out of Europe, and obviously with Dr. Fatima. Favorite fluid for me is still water. I love, for me, anytime, can't survive without water, but yes, for my patients, depending upon one size doesn't fit, so which patient requires what, at what moment of time, that will decide by its own. Thank you.
Okay, water. Like it. So I think we've got some polls to start with. Is that right?
We do. It's really funny that all our panelists has gone for all the thing. When Jamie asked the question, what's your favorite fluid? My quick immediate answer was coffee or salted caramel ice cream.
Adrian, could we ask Pietro and Anders their favorite
Yeah,
fluids?
exactly. Pietro?
Can we get the Zoom?
We'll get the Mentimeters fired up in the meantime.
Can you hear me, guys?
Yes.
Well, for me, there's no doubt that the most favorite fluid is Italian red wine. And that's obvious, also for IV infusion.
Infusion of red wine?
Yes, absolutely.
Anders?
To the courtesy of the organizers, I would say Belgian beer.
Yes.
Well done, well done. Okay, lovely. So, yeah, let's see what people out there think. We're going to go to Menti
A poll,
again
yep.
and do a poll.
So
and
all of you
some
get your
opinions.
mobile phone, smarten it up, menti.com. We're going to give you the code very shortly.
So this is a different code. If you're still on the Menti.
Yeah, so the code 86933046. So menti.com 86933046.
Okay. Do you use an empiric fluid volume for initial resuscitation? As in, do you stick to a number? So, and I guess you can say yes or no. If you say yes, could you qualify that with how much? And you can say no. Most people seem to be saying no.
What we're going to do is just go through the series of polls first, and that can frame the discussion later on. So second one. So what is your initial choice of fluid for resuscitation? Okay, mostly with balanced solutions there. Again, the resuscitation phase. Manu, are you fiddling?
Well, I was with the technical people, because you can hide the results. It's a psychological effect. If you show them immediately, everyone votes the highest column.
Okay. have gone no. I would have gone no. Okay. Thank you. Okay. Certainly for me, a very interesting range of opinions and range of answers from it. And within that, we're just going to try and dissect out certain elements of those things. We're going to start off with fluid. On the polls itself, covered a range of topics from fluid, volume, vasoactive drugs, where is it managed, so the fluid aspects, but also the delivery aspects of how these things are done. So if we can have the presentation, please, back on the center, and then we can start off with a couple of discussions. Probably the most important one, if we start at the first question, which is your choice of initial fluid choice. And the majority voted for a balanced solution, Hartmann's, Plasma Light, and the like. So I wonder what the thoughts of our panelists are on that aspect.
Go ahead, Neil.
Yeah, I think this is a great choice, of course. I'm very happy that we moved away from the colloids these days. I presume this question was about sepsis. It's not completely clear. It's the resuscitation phase, but finally, I think it's the third IFAT where we don't have the artificial colloids there, so that's a good thing. Immediately, the balanced versus unbalanced solution pops up here. And we have to admit that all the former studies that have been performed, the basic study was the last one, did not show any advantage of these balanced solutions over this saline. And I wonder why. Probably it's a volume kind of thing. All these studies, whether you're talking about the split trial or the basics trial, are very small volumes. It's 1 liter, 1.5 liter. This is probably immediately the issue with the randomized controlled trials. We have to randomize these patients in the time needed for that. Patients get the usual fluids, and for example, when this is Plasma Light, we are giving a very balanced solution with a strong ion difference of 50, and we mix it later on with an arm that is only saline, and when you have only 1 or 2 liter, I don't think it matters. What I thought what I said to my emergency department is, your first liter, just choose it. When you should choose it cheap, just to do it cheap and take physiological saline. But from the moment you need more volume, it's better that you use chloride pore solutions. I don't know the other panel, what do they think about? I think there is not much of a problem with 1 or 2 liters of saline.
Yeah. So someone asked this on the app, actually. Do you think that the basics trial has changed anything about what you do? I guess put that to someone else.
Sorry, can you?
The basics trial, so you're familiar with that. So this is Fernando Zampieri's huge trial, 11,000 patients in Brazil, randomized to receive Plasma Light or saline. And essentially, there were no difference in the primary outcomes of 90-day mortality. So flew against the SMART trial. So did it make you use saline more?
No, actually it did not, because I was taught by Paul Elbers. So we were very to use balanced fluids, and I think what's so difficult about these trials, and what you also said, that the first hour you need to give in a septic patient, obviously you need to give fluid, and it doesn't really matter what you give, and later on it does matter. But I think in these patients where so much is going on, it's so difficult in an RCT to have one thing compared when there's all these other things. And also in terms of fluids management, we also pour in so much other fluids in terms of medication, sedation, analgesics, stuff like that. I think it's impossible to really say something about this to really know if it matters or not. So it did not, but I did not start using saline more.
I think it should always be a goal to change the internal environment in the human body as little as possible. And there's so many studies where balanced and unbalanced solutions have been given to volunteers and to patients in a very controlled fashion. And it's always turn out that the balanced solutions are to prefer. And if we take a complex setting like a large group of patients, there's so many factors that can affect your result. So it's more difficult, I think, in a complicated clinical setting to disclose an effect. So it's not unexpected that they turn out as they do. I haven't changed policy. I think the balanced solutions are the mainstay of treatment, and that the unbalanced solutions are for special indications only.
Okay. I'll maybe push that a bit further then. Go on.
Let's just add on. If you have a patient with a very large I would say reserve, physiological reserve, like short-term outpatients, then I think an unbalanced solution would pass. But as the treatment gets more complicated, it becomes more important to use the small benefits there may be to manage the case.
Okay, yeah, I think clearly it is complicated. Do you think, I mean, we seem to have a pretty broad consensus for balanced solutions. Do you think the pendulum might have swung too far? Anders, go ahead.
I'll take the opposite opposition, of course. I hope you can hear me.
Yep.
Cool. So I think using the term balanced is wrong. They are not balanced. They're very far from the content of plasma water. Plasma contains acetate and gluconate, and in concentrations that the body will never see. And once these compounds enter, they are metabolized to water, which will dilute sodium, and therefore sodium will drop. So my take on basic is that we should be really concerned about patients who have brain pathology, as the subgroup analysis in TBI showed increased mortality, with what I would call buffered solutions, not balanced solutions. So if I knew nothing more about the patient, I would give saline. It appears safe, and it would be the appropriate choice in those who have potentially raised ICP.
Yeah. Okay, yeah, and that might be quite hard to tell when someone presents to the emergency department straight away exactly what the pathology is.
It is actually a very good point that Anders raises there, and I tried to wrap my mind around it too for a while. So what we're actually saying is that the balanced solutions that we use are actually, so not only the ringers, which we know are a little bit hypotonic, but also the plasmalite, which we always regarded as isotonic. We are regarding it these days a little bit more like hypotonic solutions too. It is a big thing because we don't regard them that way in our daily practice. I give plasmalite to traumatic brain injury patients all the time. So I wonder, is this a problem? I don't know. I doubt it. I wonder what happens with these acetate and these gluconate. Is it just becoming water, or is it becoming electrolytes? I don't know actually. I still regard it as an isotonic solution. I don't know you guys.
There is a consistent signal for traumatic brain injury, not just by basic trials. Even earlier trials had this consistent signal on traumatic brain injury, especially for patients with trauma. There is problem, especially giving a balanced solution. And probably I think a hypertonic is the major issue when we talk about balanced. Yes, we don't use as a balanced in the initial resuscitation. I think that what we need to differentiate. If it's a traumatic patient with an initial resuscitation, normal saline will, or so-called a saline will be a initial choice. But yes, at the maintenance phase, if you need to give some IV fluids, probably some of these patients do not start orally very early. Then we can come down to hypertonic solutions, and that's what we do. Talking about the trial per se, which Professor Andreas Perner is already here, we have been so caught up with this p-value and frequentist approach, and recently his own paper versus in COVID, not out of context, was having this similar problem. We need to look beyond this p-value at some moment of time, which we both were discussing, and especially with the mega trials, this is a very big problem because we try to, catch maximum number of patients, and that what make the mega trials, and that what lead to this so-called p-value never coming to a significant. And we tend to look at that p-value but not get the signal, which is tend to like the signal here in traumatic brain injury was very clear. But the signal for other patients where they were developing renal failure, probably because of large volume resuscitation by normal saline, was not picked up properly. So there is a way of looking up things. I think Bayesian approach may be one of that, but we need to look up these mega trials in a different way.
Okay.
Pietro's got a question.
Okay. Go ahead.
Yeah, can you hear me?
Yep.
Okay. No, but it's kind of a question from Anders, because I might have missed some novel evidence, but I don't understand why it could be a problem to use plasma light in TBI patients, because osmolarity depends on strong ions. So if also gluconate and acetate are metabolized, the osmolarity depends on the content of sodium. So I really don't understand why it should be an issue. For hypotonic balanced solutions such as ingar lactate, I know that of course this is a problem, but I don't think it's a problem with plasma light. I don't know if there are specific evidence on the use of plasma light in TBI patients, but in terms of pathophysiology, I don't think it's a problem.
Anders, I don't know if you want to come back in on that.
There's a reasonable sized subgroup analysis pre-planned in basics indicating increased mortality with the use of plasma light in TBI patients.
And did the author provide a possible explanation? Because I'm not really sure that the explanation is related to the metabolism of acetate or gluconate, unless, and maybe we don't know that yet, that these metabolites have, some detrimental effects on cerebral parenchyma and so on. But I'm not really sure that it depends on the osmolarity. Of course,
I think it's very
topic. Yeah.
Again, we are choosing between imperfect fluids. So these fluids are not plasma water. In plasma water, there's bicarbonate. We now use buffers that will be metabolized differently than bicarbonate in the body. And one explanation for the result is that acetate and gluconate is metabolized to water and thereby dilutes sodium.
But cannot be metabolized to water. They are metabolized to bicarbonate. But anyway, of course, it's an interesting aspect. I'm just saying that I'm not completely sure that this is the explanation. But of course, if there is an evidence, I think we need to, we need still to understand the rationale behind that.
Yeah, I mean, we may not know exactly how, but BASICS is a big trial, and it was, as Andrew said, a predefined, although it's subgroup analysis, not primary endpoint. But the evidence was there and safe as well, wasn't it? Yeah. So, okay. I just want to move on slightly to talk a little bit about colloid solutions, because we're really talking about crystalloids a lot at the moment. So, should we ever use colloids? Anyone on the panel think we should? Should we ever use colloids? Can we just get rid of them? Oh, Robert. Picking up the microphone angrily.
I think the first line treatment is crystalloid, and the colloids can come in if you give so much crystalloid that you fear of adverse effects, which is really when you give more than 3 to 4 liters within a day. There may be exceptions to this. I know that Pietro Caironi is exploring hyperoncotic albumin as a first-line treatment of sepsis, and that might be something to consider. It's not 100% proven yet, but that may come in later. But I think really that it can come in a situation where you are not yet ready to provide erythrocytes and blood products, and still you have given a lot of crystalloids. So in an operation, in a surgical operation, that must be in a situation where you have pretty high blood hemoglobin to begin with. Because if you have low, you get into the erythrocytes much earlier.
So obviously blood is the best colloid, probably. Or blood, give blood if you need to give a colloid. If it's indicated.
We regard it as that.
So
Maybe in intensive care, I think it's more a delicate issue when colloids come in. I won't comment on that, but others here should.
Anyone want to comment on colloids in intensive care? Anyone?
On that
Go on,
topic,
Adrian.
just curious about the members of audience that we've got here. How many of you have access to colloids in your department, in your institutions? Okay. And how many of you have access within the family of colloids? How many of you have access to the gelatin, so gelafusin, things like that? Are with me? The starches? Starches?
Only jellyfish.
Whereabouts do you work?
I have access to starches.
Okay.
Yeah. Has access.
Very important difference. Very important difference. That's a good point. Okay. And the starches, dextrans. The dextrans?
I don't think they're on the market anywhere in Europe.
Yeah, I'm from Sweden, and I used historically a lot of dextran, and a good experience with it, but now it's not available in my country anymore, so we can't have it. Otherwise, I'm sure that many would like to use it still. Yeah.
So I work in King's College Hospital in London. We have a big liver unit along with hematology oncology. We've got access to gelafusin and a couple of the starches, but at least within the intensive care units, we don't tend to use them. Our cardiothoracic colleagues quite like the gelafusin, but when you push them and ask them about it, generally speaking, is because, well, I've given so much crystalloids, I just want to give something else. That's usually their rationale thing, and I suspect, and sort of a spillover from our liver intensive care unit practice, we use a lot of human albumin. And again, is that reflective of the practice of the audience sitting here as well? Human albumin becoming more popular? Again, it's mostly, I think, because we've given so much crystalloids. If we think the gelafusins are bad, we can't get the dextrans anymore. The starches are not without problems. Therefore, by a process of elimination, we've just got left with the human albumin.
Yeah.
When you talk human albumin, it's 5% or 20%?
We've got both. We've got both.
I think it's a little sad because we kind of miss some of our tools that we have to guide fluid therapy. But I think we should work more on trying to find a therapeutic window for colloids, and that has to involve that crystalloids actually have adverse effects if you give a lot of them. So that could be a point.
Regarding the gelatins, actually they are almost crystalloids. To classify as a colloid, and I think they need to contain an agent that is over 30 kilodaltons large, and I think the gelatins are 35 or something kilodaltons. So within a few minutes they have become a crystalloid. So I think there's not much of an advantage or an added value of these gelatins. So I think you're giving crystalloids just with some bovine material in it. I never saw the advantage of it. Albumin, I agree. I fully agree. But gelatins, I think it's and they don't have much data. They have all retrospective data.
I can add a point of gelatin, as I've been very much involved in looking for pharmacokinetics of infusion fluids, and we know a lot about the colloids, but not about gelatin. Actually, very little data been published on it, although it's a very, very old colloid.
Yeah, it's from the First World War, I think.
Yeah, from the First World War.
Yes, go ahead.
May I add something from a clinical perspective? Because I understand I'm here with a few very world-renowned experts on this topic, but from a clinical perspective, and that's why I said I don't like fluids, is I think you said that after 3 or 4 liters, you know, you want to give something else or maybe consider it, but I think that the big danger of fluid resuscitation is that we tend to strive in a very sick patient normal values, normal physiology in a very, very sick patient. So I think I remember 10 years ago when I first started as a resident in an ICU, I saw the beauty of giving fluids. You give fluids, the blood pressure goes up, the noradrenaline goes down, the lactate levels drop, and you think, oh my God, I'm doing such a great job. But that's actually very dangerous. So I think in fluid, it really matters what you give, but also to really understand that you should stop yourself from giving too much because you want to manipulate the physiology of a very sick patient. So, for example, the cardiothoracic surgeons don't want to give noradrenaline. They always say give more fluids.
Well, actually, my cardiothoracic surgeons give dopamine.
or even dopamine. But I think the art of fluid management is also to really sit on your hands and not just give too much because you want to change the numbers. And I think that's what we all do, and I do it myself sometimes, and that's why I started really not liking fluid management, because later on you pay the price.
Mm-hmm. I think, yeah, we will talk about that in depth over the next couple of days, but I suppose looking at resuscitation with fluids, well, South Africa, what sort of things you do there? Would be interested to know.
So we do, touching on the albumin context, we do use albumin. It's expensive, but in the subset of septic shock patients, we do find it very useful in our patients, particularly when we use it with Lasix in the evacuation phase as well. But in the early resuscitation for small volume resus, we do use albumin. In terms of resuscitation, I think for us the big issue is the dose of fluid for resuscitation, largely because, as we all know, the literature has shown that in our environment, large doses of initial resuscitation can be very deleterious. So it's really with us, small volumes, assess response, small volumes, assess response. And we start with as little as 10 moles per kilogram, unless, of course, there's overt losses like intra-abdominal sepsis, or there's ongoing losses. And obviously, we might go higher up to 20 moles. But always small volumes and judge response to therapy, because there's very little room for error in our patients from that perspective.
And do you think the FEAST trial has changed that for you?
I think it's more the Zambian trial in the adults, where a large part of low middle income countries is really about access to ventilation, access to hemodynamic monitoring. If you fill up your patient too rapidly, you run into problems. So it's about that. Yeah, and then in terms of the BASICS trial, has that changed our practice? I think it's all about interpretation of a trial. And I think, for me, intuitively, balanced solutions make more sense, provided it's affordable for you. I think in the general population for resuscitation, post-surgery, it doesn't really make a material difference what you use. But in your high-risk patients for acute kidney injury, I think it's prudent to use a balanced solution. Basics for me didn't give me a signal either way, to be honest, largely because there was so much of crossover of fluids, both in terms of normal saline or plasma light. And the volumes were very low, the chlorides were very low. So for me, I don't know if it reflected a population where it was truly randomized. So I think it's very difficult to interpret trials nowadays. Patients are heterogeneous, and I think sometimes we have to go with what makes prudent sense. Yeah.
Okay. Anyone on Zoom want to come in there? Moving around behind. Go on then, Anders. You had your hand up first.
Yeah. So common sense, obviously. I'm not sure that, and again, I would reject still the term balanced. They are not balanced. So I find no common sense in giving high loads of acetate or gluconate. But the more important point, I think, would be to be more realistic with the potential effects of fluids and go all the way back and see, do we really know that these drugs improve circulation? Do we really know how much fluid a specific patient has lost? If they have lost some fluid, I think that would be a fair indication to give some. If they don't, I would be very reluctant in general. Probably try a bit and stop if it didn't help. I wouldn't look at blood pressure or pulse. I would probably mainly look at simple hyperperfusion markers of peripheral circulation, and sort of using that approach. At least I find it really rare that patients will need more than 2 or 3 liters of fluid in the first day, and beyond that, hardly anything. So I think actually it's quite easy to live without a colloid. I've done that happily for 10 years. Those who lose albumin, there it may be substituted. Those who don't lose albumin, I would not use it. I would be very happy to do a randomized trial also on hypooncotic albumin, but the trial data until now does really not convince me that there is benefit from albumin. And more than 10,000 patients has been randomized to albumin versus crystalloids, and it's quite difficult to see a benefit in these patients. So for me, simplification is important, and I think we may do things too complicated, in particular if we rely a lot on effects of fluids that have never been documented.
Okay. Yeah. Some really good points. I'll try to stop saying balance, but I'll probably keep saying balance. But yes, buffered or balanced solutions. Yep. Robert, did you want to come in on what Anders said?
Yeah, also, of course, when we have an intensive care case, we always try to keep down the volume of crystalloids by giving some of it, and then we measure the hemodynamics and see does it do any good, and if it doesn't do exactly what we want, we top up with an adrenergic substance, of course, norepinephrine most commonly, but also over time it's very easily that the fluid, it gets more and more and more, and we must keep track of that very carefully. Maybe it's not during the resuscitation phase so much, but later. But there's also one more thing, and that's fluid creep. And I know that Nils has published a very interesting article about that. Maybe you could comment just shortly, how much does it add to the total fluid administration?
Yeah, actually, as I'm telling for a longer time, we are always talking about these resuscitation fluids, and 99% of literature has been going about that. But actually it's almost a very, very small part of the fluids that go into patients. And what we saw in USA, in Antwerp University Hospital, in 10,000 patients, was that 1/3 of the fluids that go into patients are fluid creep, are the medication fluids. And it's very easy to reduce the chloride volume there, because you can perfectly dissolve all these medications in glucose 5%. There are only 4 or 5 exceptions.
What are they? What are the 4 or 5 exceptions?
What are the 4 or 5? It's amoxicillin, clavulanate, somatostatin, I think phenytoin, and acyclovir. These are the 4 medications that you should dissolve in sodium chloride, 0.9%, but all the rest you can choose. So we are always talking about these balanced solutions and having the chloride down. I think the chloride is the real problem there. So if you can reduce chloride level in 33% of your volume, this is probably more effective. So that's a trial that I would like to do, is not only balance versus unbalance, but just get down the chloride in all the solutions we give, in the maintenance solutions, in the fluid creep, and maybe this will give a signal, and this will be a bigger signal than the 1 liter or 2 liters that is given in the basics trial and the other trials.
So, come to you in a second. Do you think fluid creep is a problem in the resuscitation phase? I suppose as we reduce the volumes we use, perhaps switch to earlier vasopressors or inotropes, fluid creep might become more prominent, but is it something that comes later on in general?
The most fluid creep is encountered in the first few days, because then we give the most deals of medications, but it's a problem that is there for many days. Resuscitation fluids is 10 to 20% in the first day, and then it goes down to 5, 6, or even 1% in the later days. So that's actually for later, but yeah.
Okay. Do you want to say something on fluid creep, or?
Yeah, because I'm so happy that you brought it up, because I know you wrote an excellent paper on creep fluid and also how much sodium we give these people. So Adrian said we couldn't talk about COVID, but we're actually doing a sub-study now on creep fluid in our COVID patients, because in ARDS management, it's very important to you keep your patients dry. And when you look at the fluid balance every day, you think, why does this patient has an intake of 4.5 liters of fluid? And then you can see what is it. And when you open your eyes to that, you see that is a major problem. It's not resuscitation, but probably you might even give more fluids later on due to creep fluid.
Absolutely, yeah, absolutely.
Creepy fluids.
Yeah. Creepy fluids.
Yeah, definitely.
Pietro, did you want to come in online?
Yeah. Well, regarding the maintenance fluid, I totally agree with Linus. I know very well his studies, and I'm really convinced that it's an extremely big issue, especially when dealing with intensive care unit patients. After the first 3-4 days of resuscitation phase, we know that more or less 50%, even more than 50% of fluids are given just with dark dilution and fluid maintenance. And this is a big problem in terms of salt loading. And we don't have enough data so far to explore the possible clinical impact of salt loading in our patients. But I'm totally convinced that it's a big and clinically relevant issue.
A small funny thing about what you said earlier on. You said we are trying to give fluids to get the vasopressors down. The thing that I changed the past few years ago is that now I'm giving vasopressors to keep the fluids down, and I think there's more and more support of that. So these you can even give this peripheral for a short while, and that's what helped me to keep this resuscitation phase down. So the very early vasopressors, and I think there's quite some not big studies, but the attention has been growing on that.
Yeah, and I think it would be perhaps unusual in the United Kingdom, but across the world, and perhaps more in mainland Europe, that people are doing that early peripherally without invasive monitoring.
Yeah, absolutely, without much problem.
I think that's a very good signal. We started using vasopressors early, which was a concern a few years back, waiting for a bigger lumen line, but now we are doing with a peripheral cannula, and that what has changed the, as you rightly pointed out, duration of resuscitation. And I think the whole, what we all agree in last 15, 20 minutes is the volume. It's something which is related to the volume per se. It doesn't matter if whatever you have chosen in small volume, but if you are talking in volume, anything which is bigger than 2 liter, 2.5 liter should create a problem. So at least these big trials have shown a smaller volume should not be a problem. And I think that's the way forward probably. We should tend to cut down on the volume also, besides talking about just on the type of the fluid.
So, okay, volume, definitely. I think we should probably talk about the surviving sepsis guidelines because, they are quite prescriptive. So, has anyone got anything they'd like to say about these guidelines without going into depth? You can read them on the internet if you'd like.
Can I give a comment on the collid in resuscitation?
Oh, yeah.
The problem here is really that you don't know really the situation, because there can be two factors. One, it can be hypovolemia, and you're not sure about that. And in particular, if you have a septic patient that has been standing a long time before they come to intensive care, the hypovolemia can be quite substantial. And of course, that's treated with volume. But you also have in all severe disease a blunting of the adrenergic system. And the typical example of that is sepsis, but also, well, the situation is a bit similar, like if we have a higher spinal. To some degree, it can be cured with fluid because the blunting of the adrenergic system redirects the blood flows in the body, so that some parts get more and some get less, and you have to restore that to maintain organ function. But you really don't know the balance between the adrenergic system blunting and the hypovolemia. So therefore, if you give a lot of college to begin with, you have really guessed that it's hypovolemia. So that's a guess. So the best bet is to give a crystalloid judiciously, and if that does not work, you add up with an adrenergic substance. So with the possible exception of sepsis, I think that college should not be used for resuscitation. More that you titrate it with fluid first and then top up early with an adrenergic
So you've
drug.
got to examine the patient and think about what you're doing.
Yeah. Okay, that's my view on the topic.
Yeah.
You nicely showed that when you're in true shock and in true hypovolemia, a crystalloid resuscitates as good as a colloid just because of this.
That's true. Because if you have that's depending on the arterial pressure. Because if you give crystalloid and you have a very low arterial pressure, the effect is the same as of a colloid, because it cannot distribute against the higher hydrostatic pressure in the interstitium. So all fluid accumulates in the plasma. Yeah.
So fluid overload, really, yeah.
Yeah, that's a point. If you have a patient in shock, the benefit of a colloid to increase the plasma volume is virtually none.
Okay, so yeah, just moving to these guidelines that are flashed up behind us, which is surviving sepsis guidelines. So they do give some prescriptive advice about the amount of fluid we should give. So for patients with sepsis-induced hypoperfusion or septic shock, we suggest low-quality evidence that at least 30 mils per kilo of intravenous crystalloid fluid should be given within 3 hours. And the statement in 2016 is we recommend. Does everybody do? Is this aspirational? Is this something that people actually do? Does anyone do something different to this with a septic shock?
The answer lies in your poll. I think most of us are not doing it.
No, that would, the poll, I mean, it's not exactly scientific, the poll, but...
asking this is, I think, one of the key aspects of the guideline, which is coming consistently. But yes, the recommendations level has consistently gone down in last versions, from the last version, as from recommend to suggestion. But I don't know why this at least word is still coming up consistently in this particular statement. And then this within first 3 hours of resuscitation, you know, how these things are coming up. 3 hours and at least. Why at least? I don't have an idea. Maybe you can highlight.
The 30 milliliter per kilo has been criticized, and in particular by Anders Perner, who is challenging this dogma actively. In my mind, is too fixed to be a really good rule. And I think the need for fluid depends very much on the duration that the sepsis has been prevailing since you begin the therapy, because the longer the period, and probably depending also on the agent, the hypovolemia can be very, very different.
Yep. Niels?
Could it be, I'm just wondering, but could it be that a guideline has to work for New York City and rich countries such as Sweden and Holland, but also for small rural villages or rural hospitals in lower resource countries like India and Africa? Maybe this is the best fit to guide a doctor that is not going to conferences because he is just working 24/7, and that this guidance is the best we get to cover all of the world. But that in these richer countries where we can have vasopressin in an early phase and we can have monitoring in and we can have albumin to save some fluids, maybe it's easy talking for us. No, it's stupid, the 30 ml, but maybe that's necessary for countries where and maybe the most patients are treated there and not in these rich hospitals. I don't know.
So do you mean it's sort of compensating for the ability to tell if it's hypovolemia and how long the sepsis has been, or do you mean more just resources?
Yeah, I think it's more resources that the more resources you have, probably the better your capacity to avoid fluid overload. I don't know. It's just a thought.
I agree with you that part. You know, the more resources you have, the better chances you will avoid fluid overload, rather than under resuscitate. So I feel, you know, the guidelines when they go to lower middle income countries, at present, a component of that is actually causing a harm. We have seen that for the studies like FEAST and other part where, you know, especially the subset of population of sepsis is little different with a lot of tropical infections. So this, you know, dogma of using 30 ml may be in fact causing harm. But yes, if you have a better resource place, you will use early hemodynamic monitoring. You will have people who are experts, and in fact, they may not be using 30 ml. So to say this is working for a global population, in fact, I feel it's the other way around. For lower middle income countries, probably it may be having a problem and it may be causing harm.
So I fully agree that I think that if we have a high-tech hospital with hemodynamic monitoring and so on, that it can be individualized.
Yeah. Yeah. But if it can't be, should it still be at least 30 mils per kilo?
So I think these guidelines are well intended, but the reality is there's huge potential for harm, particularly for whom they really are meant to be. And that's the problem with guidelines in critical care in general, because we are in the era of personalized medicine, and we really can't be prescriptive in 2021. And for me, it just makes the case for the evidence practice gap, because guidelines don't address that. What we need is stewardship, and it lays the foundation for stewardship, because then everybody is on the same page. And I think this guideline shows that guidelines alone don't work in isolation, because if you don't have an understanding, this could be extremely dangerous.
So what do you recommend to, say, your junior doctor that says how much fluid should I give in sepsis in my emergency department? Do you say ignore the guideline, or is it a difficult one?
This is what we teach our students, that look, the surviving sepsis campaign guidelines are a general guideline about key things that you need to consider in sepsis, right? But don't take everything at heart, individualized, and we sort of, you know, if you have a pneumonia, start with 10 moles per kilo. If you've got abdominal sepsis that's delayed in presentation for 3 days, yes, go for it, 20, 30, but assess, judge, look at your hemodynamic parameters. that's the only way you can be safe. They have addressed low middle income countries surviving, sepsis guidelines, and those are not as prescriptive as this, I'm glad to say. Yeah.
Professor Pern.
Anders. Oh.
Thanks. I think I agree with most of what's been said. I sit in the guideline group. I must admit. This time around, I wasn't in the fluid part. I was in the resuscitation group the previous round, and obviously this specific recommendation at that time and still is my impression caused a lot of discussion. So it's difficult. So there's some conservatism in the group. There is sort of a reassurance that the guideline, when implemented, appears, at least in observational studies, to improve outcome, maybe not related to fluid volumes, but just in general. So I think there is some big paradox. Some of them has been pointed out very well here, that actually in the low and middle income countries, I agree, this may be harmful. We have trial data for that, the Zambian trial and obviously FEAST. To suggest that better hemodynamic monitoring should allow us to give 30 ml, it makes no sense to me. I don't think it has anything to do with hemodynamic monitoring. Again, simplicity would be important for me. So I would say, unless the patient has lost fluid, and again, we probably don't know how many sepsis patients have lost a considerable amount of fluid. So if based on history, the patient has lost fluid, fine, let's try it. If the patient is cold and clammy, fine, give 500 and reassess. So that I think is my very simple recipe. So for me, it has nothing to do with more advanced hemodynamic monitoring, and we don't know the basic stuff. And therefore, I think simplicity has a rationale, both for high-income countries and low-income countries.
Okay, thanks, Anders. That's very clear. Just going to turn to the audience in the room here in Brussels and see if anyone's got any comments on what we've been talking about. I think Marlies does.
Yeah, thank you. So I also should declare my conflict of interest. I have my name against the Surviving Sepsis Guideline, and I was involved in this discussion. And clearly, there was a lot of, as Anders already said, there was a lot of discussion, and I was one of them who struggled with the guideline from 2016. But if you try to move away from that, it's quite hard, because if there is no study looking at 10 mL per kilo versus 20. You haven't got this type of randomized control trial. You can say, oh, I think it may be too much, but that's your gut feeling. But there is no evidence really to support your gut feeling. You then look at the process trial and you look at ARISE and whatever, and in these standard care groups, that's what people got, roughly 30 mL per kilo. That's what people do in clinical practice. So then you say, well, okay, what about all these people with renal failure? They may get too much. But actually, no, there is no evidence that people with renal failure, with heart failure, could come to harm, because if you truly actually tried to find evidence to move away from this, and we couldn't. So therefore, firstly, the guideline says it's sepsis, it's not just sepsis, it's sepsis with hypoperfusion and or shock. Secondly, it was recognized and acknowledged that some people feel uncomfortable, so it's been downgraded already from the recommendation to suggestion. And if you want to downgrade it further to a different volume, there were enough people in the room at the time who were asking for it, but there was just not enough evidence to support this properly. And that's where when you go into the text, there is some discussion about this.
Yeah, that's a fascinating point about sort of usual care in process and ARISE. Actually, this is what people are giving.
Exactly.
So we sort of think, oh, well, no, we don't give that much, but we do.
Correct.
If you measure it, we do. So
when you look at process, when you look at ARISE, that is exactly what people in the standard arm got.
Okay. Well, anyone else have strong feelings about surviving sepsis guidelines and fluid management or resuscitation? Niels, go on, man.
It's actually funny. I don't know where the 30 comes from. Is it from a rise or a process? But probably it goes all the way down to the rivers, early goal therapy. Probably it's from there. But then we had another problem. The problem at that time was they didn't resuscitate well. It was after 3 or 4 or 5 hours. Resuscitation was not in the center of the sepsis approach. And the 30 came in probably there, and now we know more. Now we know fluid overload and fluid overdose and all this stuff. And the 30 remained there, but probably the number itself wasn't tested. I think we come from a problem that we under-resuscitated, and now we stick with the number that makes us over-resuscitate. Is this a correct interpretation, Marlies? Or,
Well, we stick with 30. Sorry, we stick with 30 because we have no evidence that a lower number, we have no evidence from randomized controlled trials that a lower number is better or more effective or safer, whatever you want to call it. Mm-hmm. And that is a study which then needs to be done.
Does anybody know how old is that rule to give 30 milliliter per kilo? Is it from the 90s or is it more recent?
I couldn't tell you whether the first
maybe somebody know.
I reckon noughties, early noughties, Rivers sort of time, yeah.
Because I was doing fluid balance research in the 1990s, and at that time, fluid overload was a very small issue. Mm-hmm. Nobody thought that you could overload somebody to really serious complications, and that has come later with the Brandstrup, Dilip-Lobos studies that were published 20 years ago. So if this rule is older, it has not really acknowledged that giving a large amount of fluid might be risky.
Agree. I mean, I think
just a note.
Yes, yeah, it's a very good thought. I think that these are rules, if you like, or guidelines, but they use the word suggest, and ultimately they do allow the individual clinician to have a think about it, examine the patient, and give the fluid they think is the right thing. So we need evidence, we need doctors, we need allied health professionals thinking clearly about what to do. So go on, Adrian, come on in.
A question from Marcia and then Pietro as well.
Oh, great.
Thank you. I had just one comment, one question. One comment was, I think the history is extremely important about, if the patient's been vomiting for 5 days, then clearly they're going to be much, much drier than if they just developed sepsis yesterday. But regarding the weight, I mean, if you're 70 kilos, then 30 mils per kilo over 3 hours is only 2 litres, which is probably not all that much. What I would ask is, is it the ideal weight, or if you've got a 160 kilo patient, then that's a lot of fluid, 30 mils per kilo. But we would tend to go, if with maintenance fluid, we stop at 75 kilos, so we don't go above 2.4 litres a day. And I would tend to think that you shouldn't go with the very high weights for this either, if you were following 30 mils per kilo. What do you think about that? Should it be a kind of more, well, it's a large man, he should be about 80 or 90 kilos, let's stop at that instead of...
Yeah, so essentially using ideal body weight.
Yeah.
I think that's what I would do, Adrian. Pietro?
No, just an historical comment, because as far as I remember, the first time in which 30 ml per kilogram was introduced was in the second edition of the Surviving Sepsis Campaign Guidelines in 2008. While in the first one, there was just a statement on using 500 ml or even 1 liter of fluid boluses, either crystalloids or colloids, for fluid resuscitation. And the rationale of this statement in the second edition was basically based upon the possible advantage of suggesting a fixed dose based upon a body weight. This is what has been written in the guidelines.
I just think that I would struggle to randomize patients into 10, 20, and 30 moles study because often we don't know what the deficit is. We don't know what the reserve is to tolerate that fluid. But we do know that we can give incremental volumes and judge response and be safe. So from an ethical perspective, I would really struggle to do a randomized control trial looking at set volumes, because I don't think, even if I had that evidence, I could apply it to every patient that I see. So
You might need a trial that says
I really
individualize
feel,
or don't.
Yeah,
maybe,
I really feel the guidelines should address that safety component.
Marley's.
I just want to respond to the comment, and because exactly the same was said in these discussions. So there should be ideal weight. If you have a 70-kilo person, the people in the room felt, the majority felt, that a person with septic shock would, the majority would give at least 2 liters, which comes to 30 mL per kilo. And that is what was done in the trials. And that is why it has appeared again. It's now, it says suggests, but it was generally felt that 30 mL per kilo ideal body weight was reflecting what people did. It had, over the last 15 years from the first introduction in the guideline, had generally may have contributed to the overall improvement in outcomes in sepsis management. And there was just not enough evidence that this had to be changed completely or be removed, because it may have contributed to general improvement in sepsis management. And that's why it's still there, but it did get downgraded.
Yeah.
Well, perhaps there will be, as Niels already said, a role for early use of norepinephrine. So if you do not have a central line, you start at a large bore IVR cannula in perhaps a lower concentration. So maybe that might change, is something else that might be changed, because I understand what you just said about randomizing people in these different groups.
30 mL per kilo is not that much. It's 2 liters. So if you take care about what happens immediately afterwards in the next few days, I don't think that number is that big of a problem. But you have to take care of the fluids sometime in your treatment of the patients.
Okay. Well, I just we'll wrap this first session up now. So thank you to all the panelists on Zoom and in the room, and the questions coming in from online. We talked about resuscitation. We've talked about the choice of fluids, balanced or buffered solutions, crystalloids, saline. We've talked a little bit about the evidence, and we've talked through colloids and whether we might use them. And lastly, we've been talking about guidelines for surviving sepsis and volumes. I hope that's been a good start, and we've got lots more to discuss. So I'll hand back to Adrian.
It's coffee break now between 11 and 11:30. It's across the corridor. Just to thank all the panelists, Pietro, Anders, and those on the sofa as well. On the repository, there are a couple of excellent lectures to highlight a couple of the themes that are there, such as albumin, colloids, resuscitation. They're all in a repository, which you should all have access to as well. So, coffee time.